Welcome to the Deep Dive. Today, we are taking on a health crisis that is, well, unfolding at a scale so vast it dwarfs almost every other non-communicable disease challenge of this century.
It really does.
We are talking about the global diabetes epidemic and the stunning, often silent complication that follows it, diabetic neuropathy.
The sheer scope is it's genuinely difficult to grasp. The data we pulled for this deep dive shows that 425 million people worldwide are currently managing diabetes.
425 million.
But the truly frightening numbers, the ones that keep researchers up at night, emerge when you look at prediabetes. That's the massive pool of people next in line.
Okay.
We're talking about 388 million people in China, over 130 million in India, and 85 million people right here in the United States who are categorized as pre-diabetic. It is, a demographic time bomb.
And the financial reality is just as, gravity-defying. The global cost of this disease and the endless cascade of complications it brings is consuming resources at an alarming rate.
It is. Our sources highlight that 12% of the entire world's health expenditure, a figure that rounds out to, $727 billion, is currently directed toward diabetes care.
12%. Wow.
And this cost is rising unsustainably year after year. It's a runaway train.
So within that enormous context, we're focusing today on the single most prevalent complication, diabetic neuropathy, or DN.
Exactly. This is a condition that silently and progressively affects the peripheral nervous system, touching up to half of all individuals living with diabetes over time.
So when we define diabetic neuropathy for this discussion, we're primarily zeroing in on the, let's call it the typical presentation. What does that usually look like for a patient walking into a clinic?
It generally means distal symmetric polyneuropathy, or DSP. This is a length-dependent nerve injury. It manifests as a loss of sensory function, and it typically starts at the toes and moves proximally up the leg.
That's the stocking distribution I've read about.
That's the stocking distribution. And eventually, it can sometimes affect the hands, which gives us the glove part of the stocking and glove pattern. It causes severe morbidity, ranging from profound numbness to chronic debilitating pain.
So our mission today is, frankly, ambitious. We need to unpack the complexities that researchers are really struggling with right now.
That's right.
That means understanding the massive difference in how type 1 and type 2 diabetes respond to treatment, drilling down into the microscopic cellular mechanisms that actually poison the nerves.
And reviewing the latest strategies for diagnosis and, critically, for pain management, which now includes very explicit public health mandates against the long-term use of opioids.
That part is huge.
It is. And the urgency of this deep dive, it really lies in the future projections. If we do not develop successful interventions, and I mean therapies that modify the actual disease progression, not just mask the symptoms,
Right.
it is conservatively estimated that by 2050, 1/3 of the global population will have diabetes. And half of those will develop neuropathy. This isn't just a clinical problem. It's a looming global health crisis that demands we understand the modifiable risk factors and the avenues for effective intervention.
Now, okay, let's start with part one. The epidemiology, the risks, and the diverse patterns of nerve damage. We know the global cost is astronomical, but what's the specific financial and physical impact of DN in a country like the United States?
The financial burden is immense. In the U.S., the annual cost attributed directly to diabetic neuropathy and its related complications, so, think foot ulcers, amputations, chronic pain management, it exceeds $10 billion.
$10 billion a year.
But that financial cost is really just a proxy for the human cost, for the morbidity. DN is a huge factor in a patient's decline. It increases the risk of falls dramatically, it causes chronic pain that severely diminishes quality of life, and it leads to hospitalization and disability.
So to put this in context, if someone walks into a clinic with just generalized neuropathy, how often is diabetes the culprit?
Diabetes is the dominant factor. Population studies consistently find that between 40 and 55% of all cases of generalized neuropathy are attributable to diabetes.
So it's basically a coin flip.
It's the first thing you have to rule out. Even when you account for age, where the incidence of neuropathy naturally rises sharply.
Right.
It jumps from less than 50 cases per 100,000 person years in those under 50 to around 300 per 100,000 in those over 75 diabetes, still accounts for 1/3 or more of those cases in older populations.
So diabetes is always suspect number one. Let's dig into that fascinating and, I think, critical difference between type 1 and type 2 diabetes patients when we talk about incidence versus prevalence of DN.
This contrast, it gives us vital clues about the underlying causes. If you look at incidence, So the rate of new cases developing each year, it is actually significantly higher in T2DM patients.
Higher in type 2.
Yes, around 6,100 per 100,000 person years. For T1DM patients, the incidence is lower, at 2,800 per 100,000 person years.
Okay, yet the prevalence, a total percentage of people living with DN at any one time, is similar for both groups, roughly ranging from 8% to 51%. So if type 2 patients are developing new cases faster, why isn't their overall prevalence just dramatically higher?
It's a great question, and there are a few likely explanations. First, T2DM tends to have a much longer, often uncontrolled pre-symptomatic period before diagnosis,
The silent period.
the silent period. So the nerve damage may already be underway before the clock even starts ticking on their diagnosis. Second, T1DM patients typically develop the disease much younger, meaning they're exposed to the risks of hyperglycemia for a far longer duration over their lifetime.
Ah, so the total exposure time is longer.
Exactly. The T1DM incidence rate is lower per year, but the lifetime exposure is much longer. This allows the cumulative prevalence to catch up. What is absolutely clear, however, is the speed of acceleration in T2DM.
What does that look like?
In observational studies that tracked T2DM patients for just 10 years, the prevalence of DN exploded from 8% to a really concerning 42%.
From 8 to 42% in a decade. That's terrifying.
It shows the damage accelerates rapidly once the metabolic disease takes hold.
Okay, so we've focused on the common DSP pattern, the stalking and glove numbness and pain. But diabetes causes damage across the entire nervous system. What are the other major forms of neuropathy we need to be aware of?
The second major group, and arguably the most dangerous, are the autonomic neuropathies. These affect the involuntary functions of the body, things like heart rate, digestion, bladder control,
The systems that run in the background.
the systems you take for granted until they stop working.
So how does that manifest in, say, the cardiovascular system?
In the heart, it presents as cardiac autonomic neuropathy, or CAN. This damages the nerves regulating your heart rate and your blood vessel diameter. It can lead to orthostatic intolerance, that generalized weakness or lightheadedness when you stand up too quickly.
Or even fainting.
Or even syncope or fainting, yes. CAN is a very serious predictor of cardiovascular mortality, and it's often clinically overlooked.
And when the gut is affected, what happens there?
That leads to significant gastrointestinal dysfunction, primarily gastroparesis. The nerves that control the stomach's emptying are damaged, so motility slows right down.
So food just sits there.
Exactly. Patients suffer from chronic nausea, bloating, a feeling of being full after just a few bites,
Early satiety.
and sometimes cyclical vomiting after meals. From a diabetes management perspective, this is a nightmare because delayed stomach emptying makes carbohydrate absorption completely unpredictable.
So their glucose control just becomes impossible to manage.
It becomes brittle, highly volatile, really, really difficult.
What about the urogenital system?
There we see diabetic cystopathy, where bladder nerves are damaged. This can range from the inability to fully empty the bladder, which leads to urinary retention and infections, all the way to incontinence.
And sexual function.
It's highly common. Impotence in men and in women, reduced lubrication, reduced libido, or even pain during intercourse. These forms of neuropathy, they dramatically impair daily function and relationships.
You also mentioned focal neuropathies earlier.
Yes, focal neuropathies are less common, but they're important to recognize. They represent the dysfunction of individual peripheral nerves, what we call isolated mononeuropathies.
Like carpal tunnel.
Carpal tunnel syndrome is a classic example, median nerve damage at the wrist. Or, less frequently, radiculopathy, which is nerve root involvement that causes pain or weakness in a very specific confined pattern.
Before we move on to risk factors, let's just revisit that critical and sort of counterintuitive form of neuropathy caused by the treatment itself. Treatment-induced neuropathy.
This is a truly paradoxical and, I think, under-recognized complication. It happens when clinicians aggressively try to normalize high glucose levels too quickly.
So you're trying to do the right thing, but you do it too fast.
You do it too fast. It's what we call over-aggressive glycemic control. The rapid metabolic shift appears to injure the already stressed nerves. It can mimic the symptoms of DSP or autonomic neuropathy, sometimes quite severely.
So the clinical takeaway there is what? Slow and steady wins the race.
Pretty much. For patients with very high, long-standing glucose levels, rapid normalization is not necessarily safer. We have to aim for personalized, good control, not just the absolute lowest number as fast as possible.
That leads us perfectly to risk factors. If rapid glucose lowering can be dangerous, What are the primary established predictors for developing DN in the first place?
The two undisputed classic major predictors are the duration of diabetes.
Hmm.
Simply, the longer you have it, the higher the risk, and the extent of hyperglycemia, which we measure with hemoglobin A1C or HbA1c levels.
But, and this is a huge but, we have to stress the powerful data emerging from type 2 diabetes studies that points beyond just glucose.
We absolutely do.
Yeah,
You're talking about the metabolic profile acting independently.
exactly.
The data is crystal clear. The number of metabolic syndrome components a TTDM patient has, so we're talking hypertriglyceridemia, hypertension, abdominal obesity, and low HDL cholesterol, is consistently and powerfully associated with DN risk.
And here's the profound point, right? This association holds up independent of their glycemic status.
That is the profound point. A patient might have decent HbA1c control, but if they have 3 or 4 components of the metabolic syndrome, their risk for DN remains exceptionally high.
So this fundamentally reinforces the idea that DN isn't simply a sugar poisoning problem. It's a systemic energy and nutrient overload issue that goes way beyond just glucose metrics.
That's the modern understanding, yes. It's a whole body metabolic disease.
What other independent risk factors do we see in the literature?
Other factors include smoking, which constricts blood vessels and increases oxidative stress, alcohol abuse, and interestingly, increased height.
Increased height. Why is that?
The longer the nerve, the more vulnerable it is to that length-dependent dying back process we talked about. More highway to maintain, and of course, older age, which simply provides more time for all this chronic metabolic damage to accumulate.
And what about genetics? Are we close to identifying a high-risk genotype for this?
Researchers are investigating polymorphisms in specific genes, like ACE and MTHFR, but the progress has been slow. While specific genetic vulnerabilities likely exist, compared to the overwhelming and immediate impact of the metabolic environment, the high sugar, high lipids, high blood pressure, the overall role of genetics remains largely unknown as a dominant, actionable predictor.
Okay, let's transition into part 2, where we unpack the microscopic war happening inside the nerves, the cellular and metabolic mechanisms of injury. You describe DN as a length-dependent disorder that follows that dying back process. How does that damage physically occur within the axon?
The axon, which is that long cable extending from the neuron cell body, is targeted first at its most distant point. Think of it like a highly efficient supply chain that starts to fail.
Okay.
The long axons that reach your toes require constant maintenance, energy, and structural replenishment from the cell body, which is, miles away in relative terms, back in your spine. When that supply chain fails, the farthest tip of the axon starves and begins to retract.
The dying back phenomenon.
Exactly. The longest nerves are damaged first, which is what leads to that distal, stocking-like presentation.
And where does the initial insult occur? I mean, is the axon dying because the cell body stopped sending supplies, or is the axon itself being attacked from the outside?
That has been the central debate for decades.
Mm-hmm.
Is the primary damage to the axon itself, or to the cell body, the perikaryon, located in the dorsal root ganglia, the DRG?
Right.
And while some theories emphasize damage only to the Schwann cells in the distal axon, recent, more comprehensive evidence suggests that the entire neuron, the cell body, the supporting structures, and the axon is targeted almost simultaneously by this hostile metabolic environment. It's a structure-wide systemic failure.
Let's focus on those crucial support structures, the Schwann cells. We often hear about them in the context of demyelinating diseases, but what is their role in diabetic neuropathy?
While DN isn't primarily a demyelinating disease, chronic hyperglycemia and hyperlipidemia absolutely impair the function of Schwann cells. They are the essential infrastructure engineers for the axon.
The road crew.
The road crew, exactly. They regulate the cytoskeletal properties, basically the internal scaffolding of the axon. They provide critical trophic or growth factors to keep it healthy.
And you mentioned something incredibly specific in the outline, ribosome transfer. How does a Schwann cell provide maintenance for an axon that can be, a meter long?
This is just a beautiful piece of biological collaboration. Schwann cells don't just sit there. They actively transfer small vesicles filled with ribosomes to the adjacent axon.
And ribosomes are the cell's protein factories.
They're the little protein factories. So think of the axon as this massive, constantly used highway. When it gets stressed or damaged, it needs to be able to repair itself locally, far from the main factory in the DRG. By receiving ribosomes from the Schwann cell, the axon can maintain local protein synthesis.
Like having little mobile repair crews stationed along the highway.
Perfect analogy. When the Schwann cell is compromised by diabetes, this ribosome transfer, this maintenance crew delivery, it stops. And that accelerates the neglect and subsequent death of the distal axon.
That provides a really clear picture of why the distal nerve dies. But what is happening back in the cell body, the DRG perikaryon, that mirrors this stress?
The pericardia show signs of catastrophic structural failure. In chronic P1DM models, we see a progressive inability to synthesize and export neurofilament polymers.
Which are?
These polymers are the structural scaffolds, the steel beams of the axon. If the manufacturing hub, the DRG, can't produce and ship out the structural materials, the axon will inevitably lose its integrity and collapse, regardless of what the Schwann cells are doing.
And this structural failure is driven by intense cellular stress. Can you define some of the specific stress mechanisms we see in the DRG?
Sure. Preclinical studies consistently point to several specific failures. We see massive oxidative damage, which leads to abnormal protein processing and endoplasmic reticulum stress. The cell's quality control system just breaks down.
So it's making faulty parts.
It's making faulty parts and can't clean them up. Key molecules fail. GAP43, which is essential for nerve regeneration, malfunctions. Datatubulin, vital for the internal transport tracts within the axon, gets damaged. HSPs, the heat shock proteins, which are usually protective chaperones that shield other proteins.
And they get overwhelmed.
They get overwhelmed. And PRP, a DNA repair enzyme, becomes hyperactive. And in doing so, it just completely exhausts the cell's energy stores.
That sounds like a long list of targets. I mean, is there any evidence that modulating these highly technical pathways can actually lead to recovery?
Yes, and that is the glimmer of hope here. For instance, regulating the activity of HSP90, one of those heat shock proteins, has been shown in models to rescue mitochondrial function.
And if you fix the mitochondria?
You fix the mitochondria, you restore the cell's energy production. This led to clinically relevant improvements, specifically better nerve conduction velocity, or NCV, and improved thermal and mechanical responses. It shows that DN isn't necessarily a one-way street of degeneration.
Okay, let's get to the core pathogenesis, substrate overload. This explains why all this damage occurs. How does the excess energy, the excess sugar and fat poison the nerve cells?
The problem is saturation, driven by the massive intake of metabolic fuel. In diabetes, both glucose, which is metabolized through glycolysis in the TCA cycle, and fatty acids, metabolized through beta oxidation, they just overwhelm the cell's processing machinery.
Too much fuel for the engine.
Way too much. There is simply too much incoming substrate for the energy system to handle efficiently.
And when the system saturates, the dangerous byproducts appear. Specifically, how do fatty acids become toxic?
When the fatty acid transport and processing system is saturated, the intermediate molecule acetyl-CoA, instead of moving efficiently into the energy cycle, gets shunted toward the production of these toxic byproducts called acylcarnitines.
Acylcarnitine.
These are highly reactive molecules that accumulate, particularly in the Schwann cells, and are then released. Acylcarnitines function as metabolic toxins. They directly induce mitochondrial dysfunction and promote the degeneration of the adjacent axon.
So that's a clear demonstration that lipid toxicity, separate from glucose, is driving the progression of DN.
Absolutely. This excess fuel also ignites the second major driver, oxidative stress.
Right.
The substrate overload forces the oxidative phosphorylation chain, the cell's ATP factory, into overdrive. It fails to keep up, leading to a massive increase in reactive oxygen species, or ROS, which you probably know as free radicals.
And that surge of ROS causes mitochondrial failure, which you said is a triple threat.
It's a triple threat. It limits ATP production, it damages the mitochondrial structure itself, and critically, it inhibits the normal trafficking of mitochondria down the axon. If mitochondria can't move to the distal tip of the axon, that tip starves and dies. Simple as that.
And this oxidative stress links directly to inflammation via these things called advanced glycation end products.
Correct. Elevated glucose reacts non-enzymatically with proteins, fats, and nucleic acids, creating AGs, or advanced glycation end products. These altered molecules change protein function, and when they bind to their specific receptor, RAGE, they trigger a potent inflammatory response, releasing pro-inflammatory molecules and a flood of more free radicals.
So it's a self-perpetuating cycle of damage.
It is.
And we also noted that fat, or hyperlipidemia, contributes its own set of damaging molecules.
It does. Hyperlipidemia generates more ROS and initiates local inflammation through macrophage activation. Furthermore, when low-density lipoproteins, LDLs, are oxidized by ROS, they become highly toxic.
The bad cholesterol becomes even worse.
It becomes actively poisonous. These oxidized LBLs bind to specific receptors like LOX1 and TLR4. This binding triggers specific death cascades, including caspase-3 activation, which directly leads to progressive nerve injury. This shows the dual assault. DN is poisoned by both high sugar and oxidized fats.
Let's shift away from the neuron itself and look at the environment around it, specifically the blood supply. How does microvascular dysfunction play into this?
Microvascular dysfunction is considered a crucial secondary mechanism of nerve injury. Peripheral nerves, like all tissues, require a consistent, healthy blood supply via these tiny vessels called the vasa nervora.
The nerve's own blood vessels.
Literally, yes. And we see clear pathological findings. The basement membrane of these blood vessels thickens, which restricts blood flow, and this thickening correlates directly with the severity of the nerve damage. Core vasodilation, the inability of those arterioles to open up and supply blood, actually precedes measurable decreases in nerve conduction velocity.
So the nerve is being starved of oxygen and nutrients before it even starts to fail electrically.
Exactly. It's an ischemic injury on top of a metabolic one.
If the nerves are starved, is improving blood flow a viable therapeutic strategy?
Preclinical evidence suggests it is. Treatment with vascular endothelial growth factor, or VEGF, in diabetic rat models significantly increased both nerve conduction velocity and the density of the vasa nervora.
So it grew new blood vessels?
It did, which proves that targeting microvascular issues, maybe as an adjunct to metabolic control, is a really promising avenue for future therapy.
Now let's revisit the insulin paradox. We mentioned that insulin acts as a neuronal growth factor. For type 1 diabetes, insulin is a huge win for preventing DN. Why is that?
Insulin receptors are expressed directly on DRG sensory neurons. So insulin acts as a powerful neurotrophic factor. It's essentially a growth and maintenance signal.
Okay.
In T1DM, where insulin is deficient, replacement therapy not only lowers glucose, but it provides that essential trophic factor signal to the nerves. The landmark DCCT trial proved that tight glucose control in T1DM achieved with insulin provided substantial long-term therapeutic benefit against DN progression.
But the situation is completely different in T2DM.
It is. T2DM patients develop neuronal insulin resistance. It's the same principle as a resistance in muscle or fat tissue, but here the neurons themselves become deaf to insulin's growth factor signals.
Wow.
This resistance, which is specifically linked to altered phosphorylation of insulin receptor substrate 2, or IRS2, means that even if you flood the system with insulin to control glucose, the nerve does not get the message to heal itself or stop progressing.
So the repair signal just isn't being received.
The call is coming from inside the house, but no one is picking up the phone. This resistance mechanism is why traditional insulin treatments, while vital for glucose control, are largely ineffective at halting DN progression in T2DM patients.
That is profound. It suggests that T2DM isn't just a deficiency state, it's a communication breakdown that fundamentally prevents the nerve from utilizing its own repair mechanisms. When the degeneration progresses, many patients develop this chronic, debilitating pain. This brings us to part 3. Neuropathic pain, driven by neuronal hyperexcitability and central nervous system changes.
Neuropathic pain is defined as pain caused by a lesion or disease of the somatosensory nervous system. It affects 30 to 50% of DN patients, and for many, it is the complication that reduces their quality of life the most significantly.
How do patients typically describe this type of pain? What does it feel like?
The hallmark is spontaneous pain, a deep burning sensation, typically starting in the feet. But what makes it truly debilitating are the paradoxical symptoms.
Paradoxical how?
They often report intense pain to things that shouldn't hurt, like brush-evoked allodynia, where the light touch of a bedsheet or a sock causes severe agony. Compounding the misery, this intense pain often coexists with profound sensory loss.
So their feet are intensely painful, yet numb to protective touch at the same time.
Exactly. It's a cruel combination.
When assessing risk for developing this specific painful phenotype, are there certain factors that stand out?
There are. We see female sex, greater severity of the underlying neuropathy, poor glycemic control, impaired kidney function, and higher body mass index, all associated with a higher risk of painful DN.
Let's look at the peripheral mechanism of this agony. We know the nerve is injured, but the pain is driven by the nerve becoming hyperexcitable. What does that mean microscopically?
It means the injured sensory neurons, the primary efferents that should only fire when something damaging happens, start firing spontaneously and erratically, even when there is absolutely no stimulus.
They're just firing on their own.
They're generating their own noise. This continuous aberrant signaling is the engine of neuropathic pain, and clinicians can confirm this. If you apply a local anesthetic block to the peripheral nerve, The ongoing pain often resolves, proving that the hyperexcitability of those peripheral nerves is the critical driver.
So the key to treating this pain is understanding which ion channels are being altered to cause the spontaneous firing.
That's where all the research is focused. The key actors are the specialized voltage-gated sodium channels, or VGSCs, particularly NaV1.7, NaV1.8, and NaV1.9, which are enriched in the nociceptors, the pain-sensing neurons.
And NaV1.8 is especially critical.
It is. In painful DN, its expression is often increased. By increasing NaV1.8 expression, the nerve reduces conduction failure in its C fibers, which allows a torrent of nerve impulses to be successfully transmitted up to the spinal cord. That massive increase in afferent signaling is what drives the pain.
And this hyperexcitability is exacerbated by the metabolic environment of diabetes itself, correct?
Absolutely. One of the reactive metabolites elevated in diabetes is methylglyoxal. Methylglyoxal can bind to and modify the NaV1.8 channel protein, resulting in a gain of function.
So the channel becomes overactive.
This chemical modification makes the channel stay open longer or open more easily, pushing the sensory neuron over the threshold into continuous spontaneous firing. It's a direct link between metabolic stress and the pain generation mechanism.
This sounds like a classic gene-environment interaction. The genetic sets the stage, and the metabolic stress triggers the pain.
That is an excellent way to put it. We know that rare gain-of-function variants in the SCN9A gene, which encodes NaV1.7, are statistically more common in patients with painful DN.
And what's fascinating about that?
What's fascinating is that many patients with these genetic variants reported no pain their entire lives until the metabolic stress of diabetes, the environmental factor, altered the function of that channel. The gene loaded the gun, and diabetes pulled the trigger.
Are there other channels involved in damping or amplifying this signal? What about the brakes?
Yes, the body has natural brakes on neuronal firing, primarily mediated by specific potassium channels, the shaker-type potassium channels. In DN, the expression of these brake channels is reduced in myelinated axons, removing that natural suppression mechanism.
So the accelerator is stuck on and the brakes are failing.
Precisely. And to make matters worse, the activity of the calcium channel Kv3.2 is enhanced, possibly through glycosylation, further pushing the DRG neuron toward hyperexcitability.
Now, if the peripheral nerves are shouting continuously, what happens when that excessive input reaches the central nervous system, the spinal cord, and the brain?
That is the definition of central sensitization. The enhanced spontaneous input from the injured peripheral nerves floods the spinal cord dorsal horn. The central neurons there become hyperresponsive. They turn the system's volume up way too high.
And the result is?
The result is amplified pain responses. A mild stimulus, like a brush, causes a disproportionate agonizing pain response.
Does the central nervous system's own immune system get involved in this volume adjustment?
It plays a crucial role. Microglia, the immune cells resident in the CNS, shift into a pro-inflammatory phenotype in DN. These activated cells release powerful chemical signals, notably brain-derived neurotrophic factor, or BDNF.
And what does BDNF do?
BDNF acts directly on the spinal cord synapses, increasing their sensitivity and amplifying nociceptive signaling. Glial activation is a major factor driving the chronic mechanical hypersensitivity we see in these patients.
And what about changes in the brain itself? Does chronic pain structurally alter the brain?
It absolutely does. We see clear evidence that chronic pain fundamentally changes the entire pain network. Firstly, the descending pain modulatory system, the system originating in the brain that normally sends signals down to the spinal cord to inhibit pain, is impaired.
So the brain's own pain control system fails.
It fails. Data suggests that spinal disinhibition contributes significantly to the pain experience. Furthermore, structural changes are observable. fMRI studies show patients with painful DN exhibit increased pain facilitation, particularly through the ventrolateral periaqueductal gray region.
And you mentioned actual structural changes, like atrophy.
Yes. We also see structural atrophy, including a greater reduction of the lambic gray matter volume compared to DN patients who do not experience pain.
This confirms that what starts as a metabolic injury in the foot becomes a complex, chronic remodeling of the entire central and peripheral nervous system. It's not just in their feet anymore.
It is a disease of the entire nervous system by that point.
Okay, let's move to part 4, diagnosis, screening, and prevention. Given all the complexity of the pathology we just discussed, how is DN actually diagnosed and staged in everyday clinical practice?
Despite all that complex science, the reality is that the vast majority of DN diagnoses are made based solely on patient history and a thorough physical examination,
Really? That's it.
for the most part. Objective confirmatory testing with specialized tools is typically reserved for research or for when the patient presents with an atypical pattern that suggests a non-diabetic cause.
So what are the key elements of the history that guide the diagnosis? What are physicians listening for?
They're listening for reports of that length-dependent progression. Numbness, tingling, burning pain, weakness, and unsteadiness, always starting at the toes and gradually spreading upwards.
And the physical examination? How do clinicians quickly differentiate between different types of nerve damage?
The exam aims to differentiate between two major fiber types. First, the small fibers are tested for pain using a pinprick and for temperature sensation. Then, the large fibers are tested for vibration and proprioception, which is joint position sense.
And how is it done?
The testing method is standardized. You apply the stimulus to a normal region first, like the face or wrist, to ensure the patient understands the sensation they're looking for. Then you start at the great toe and move proximally up the leg until the patient reports the sensation returns to normal.
So you're literally mapping the line of sensory loss.
You're mapping the extent of it, yes. We also look for the loss of ankle reflexes, which often occurs very early in the disease process.
And for formally staging the disease and assessing severity.
For that, clinicians often use standardized clinical scales like the Toronto Clinical Neuropathy Score or the Michigan Diabetic Neuropathy Score.
When do objective tests like nerve conduction studies become necessary?
Nerve conduction studies, or NCS, are the mainstay for assessing large fiber function. They can confirm damage by revealing decreased electrical signal amplitudes, slowed conduction velocities, or prolonged F responses.
But, and this is a critical point for clinicians, right? NCS results will be entirely normal in patients with a pure small fiber neuropathy.
That is a critical point. These are the patients who have severe burning pain but often get inconclusive tests, which can be incredibly frustrating for them.
So if NCS is normal, but the pain and symptoms are classic for small fiber DN, how do researchers definitively confirm the diagnosis?
The gold standard, which is usually only done in specialized research centers, is the intraepidermal nerve fiber density, or IENFD, assessment.
And that involves a biopsy.
It requires a tiny 3mm skin punch biopsy, typically from the calf, to literally count the number of nerve fibers crossing the basement membrane. A reduced count confirms small fiber loss.
Are there less invasive tools?
There are, though they're still specialized. Things like quantitative sensory thermal thresholds, which measure temperature perception, and corneal confocal microscopy, which actually measures nerve fibers in the transparent cornea of the eye.
Now, let's talk prevention and screening. What are the current guidelines for catching this early?
The standard guidelines from the American Diabetes Association, the ADA, mandate annual screening for T2DM patients starting right at diagnosis, and for T1DM patients starting 5 years after diagnosis. Early identification is absolutely key.
And the most effective screening tools are often the simplest ones.
Exactly. The two highly reliable and simple tools that should be performed in every annual checkup are the 10-gram monofilament test and the 128 Hz tuning fork.
Oh, no, sorry.
The monofilament assesses pressure sensation, and the tuning fork assesses vibration. A critical finding is that insensitivity to that 10-gram monofilament is one of the single strongest predictors of high risk for foot ulceration.
Which is the precursor to amputation.
Exactly. So these simple, inexpensive tools provide both diagnosis and powerful risk assessment.
Let's turn back to the hard truth of prevention strategies. We discussed the paradox earlier, but let's look at the landmark data contrasting type 1 and type 2 diabetes.
The data provides a really jarring contrast. For T1DM patients, enhanced glycemic control profoundly reduces the incidence and slows the progression of DN. The Diabetes Control and Complications trial, the DCCT, showed that intensive glucose control provided significant, durable, long-term neuroprotection.
So for type 1, tight glucose control works. Why then does that success not translate to type 2?
Because T2DM is a fundamentally different disease at the cellular level, characterized by that neuronal insulin resistance and the metabolic syndrome. The effect of aggressive glucose control in T2DM trials is much, much smaller and often statistically insignificant for DN progression.
And in some cases, it was actually harmful.
It was. Studies like the ACCORD trial actually demonstrated that aggressively targeting an HbA1c below 6% in T2DM patients was associated with increased cardiovascular events and mortality.
So the standard of care is completely different. You cannot apply the T1DM strategy to T2DM.
That's right. For T2DM, the standard of care has shifted away from simply chasing the lowest possible HbA1c number. Instead, the focus is on achieving good, personalized glycemic control within a holistic, multi-factor approach, meaning prioritizing aggressive lipid control, managing hypertension, and addressing all the metabolic syndrome components, knowing that these factors drive DN independently of glucose.
Given the lack of reliable pharmacological prevention in T2DM, there's massive interest in non-pharmacological interventions, particularly structured exercise. Is the evidence strong enough to show exercise can truly regenerate damaged nerves?
The evidence is becoming increasingly robust, and it suggests a genuine regenerative capacity. We have compelling data from studies involving diabetic patients who are not yet diagnosed with neuropathy.
Okay, so a preventative model.
Exactly. A structured exercise program combining aerobic and resistance training led to a measurable increase in distal leg, i.e. NFD. It boosted nerve fiber density by an average of 1.5 fibers per millimeter.
And the control group?
The counseling-only control group showed no such improvement. This suggests exercise stimulates neurotrophic factors and potentially improves local microcirculation, leading to quantifiable nerve regrowth.
Does exercise still help patients who already have established neuropathy and pain?
Yes. Several studies show that even in established DN, consistent aerobic and strengthening exercise regimens improve outcomes. They've been shown to improve IENFD, even in the more proximal thigh, and significantly reduce neuropathic symptoms, crucially including pain intensity and frequency.
And that's independent of weight loss?
Often independent of significant weight loss. It appears to be a direct neuroprotective and a regenerative mechanism, making exercise a potent, disease-modifying intervention that we should be prescribing far more frequently.
What about other profound metabolic interventions, like bariatric surgery?
They've shown promise. One prospective cohort study saw improved neuropathy outcomes just 6 months post-surgery, and this was independent of glucose normalization. But we still need larger, controlled trials to definitively establish bariatric surgery's preventative power for DN long-term.
That sets the stage for Part 5, pain and disease management. And this is the section where we confront the painful reality that science has largely failed to develop a disease-modifying drug.
This is perhaps the most sobering aspect of DN. The record of clinical trials is one of repeated failure. Since the 1980s, over 70 major clinical trials have been conducted for disease-modifying therapies, many of them centered on a single family of drugs, aldose reductase inhibitors, or ARIs.
And the result?
Every single one of them failed to gain widespread regulatory approval in major markets like the U.S. This highlights just how fundamental and complex the multi-layered pathogenesis of DN really is.
One agent that constantly resurfaces, though, is alpha-lipoic acid, or alpha-lipoic acid. It's often used in Europe and elsewhere. Why hasn't it gained traction in the U.S. if some trials showed symptom benefit?
This is a crucial distinction between symptom management and disease modification, and it's why regulatory bodies are so strict. The SY-DENY-2 trial did indeed show clear symptom improvement. It achieved a 51% reduction in the total symptom score at a 600 milligram daily dose, which is great news for pain relief. But the largest, longest, and most robust trial, the 4-year Nathan I trial, failed to meet its primary composite endpoint. That endpoint combined objective measures of nerve impairment scores and neurophysiological tests.
So patients felt better, but objectively the disease was still progressing just as fast.
Exactly. Regulatory bodies like the FDA require evidence of disease modification, that the drug halts or reverses the underlying pathology, not just subjective symptom relief. Because that primary objective endpoint was not met, even though secondary symptom endpoints showed some marginal benefit, the drug cannot be marketed as a treatment for DN in the U.S.
What about other agents researchers have tried and failed with?
Well, benfotiamine, a derivative of thiamine, showed some promising but borderline results in short-term trials. However, a comprehensive long-term 24-month trial found no significant benefit on peripheral nerve function.
Okay.
PUFA supplementation, polyunsaturated fatty acids like omega-3s, has shown promising pilot results, improving corneal nerve fiber length. But we urgently need much larger controlled trials to confirm that efficacy. And as we mentioned, ARIs like epilrostat, which are marketed in Japan, have failed to prove widespread efficacy in Western populations.
So given this huge bottleneck, managing the pain is the immediate, unavoidable reality for 30 to 50% of patients. What is the consensus approach for first-line pain management?
The consensus from every major clinical guideline, the ADA, the American Academy of Neurology, the Neuropathic Pain Special Interest Group, they all identify 3 drug classes with the most robust, high-quality evidence for first-line use.
Okay, what's number 1?
First, we have the alpha-2 gilta ligands, which are anticonvulsants, primarily gabapentin, and pregabalin. Pregabalin is highly effective, demonstrating a 30% to 50% reduction in pain scores in numerous trials.
But there are cautions.
We must emphasize caution, yes. They carry adverse effects like confusion, sedation, and dizziness, which are particularly pronounced and dangerous in older patients. Gabapentin remains a common choice due to its current lower cost, though pregabalin often has a better predictability of effect.
The second class are the SNRIs, or serotonin and noradrenaline reuptake inhibitors.
Specifically, duloxetine and venlafaxine. Duloxetine is particularly well established and, beyond just pain relief, has been shown to significantly improve neuropathy-related quality of life.
And the trade-off.
The trade-off is often a higher incidence of general adverse effects, such as nausea, dry mouth, or insomnia, compared to the alpha-delta ligands.
And the third class, the older tricyclic antidepressants, or TCAs.
Yes. TCAs, including amitriptyline, nortriptyline, and disoprimin, have proven efficacy in smaller but consistent trials. For older adults, clinicians often prefer nortriptyline and disoprimin as they have a slightly better side effect profile regarding anticholinergic effects and sedation, although they have less large-scale trial data than the others.
Finally, we must talk about the public health mandate regarding opioids. What is the strong position of every major health organization on using opioids for chronic DN pain?
The position is overwhelmingly strong. Avoid them. The CDC, the ADA, and the AAN guidelines all strongly recommend against the long-term use of opioids for chronic non-cancer pain, which includes DN.
Even though they work for pain.
Yes, and while there is evidence showing pain efficacy for atypical opioids like tapentadol and tramadol, or even for stronger classical opioids like oxycodone in small trials, the substantial risks associated with tolerance, dependence, addiction, respiratory safety, and increased all-cause mortality mean they should be strictly excluded from first or second-line management of DN pain.
The bottom line is the risks profoundly outweigh the long-term benefits.
Profoundly.
We've examined the physical disease and the pain management struggle. Now we turn to part 6, quality of life and the path forward. What is the holistic burden of living with this condition?
Diabetic neuropathy imposes a deep mental and physical toll. The constant demands of glucose monitoring, the fear of complications like foot ulcers, and the burden of chronic pain contribute to a condition often described as diabetes distress.
Which is different from clinical depression.
It's distinct from clinical depression, but it significantly impacts their ability to manage their condition. It's a burnout from the disease itself.
And when chronic pain is added to that, the quality of life impact is magnified substantially.
Absolutely. Painful DN causes significant sleep impairment, which leads to chronic fatigue. It is directly linked to high rates of anxiety and clinical depression and dramatically reduced productivity and social function.
And this burden extends even to the final stages of the disease, such as when amputation is required.
Yes, when it's required due to intractable infection or severe neuropathy.
What specific psychological support is now recognized as necessary for these severe end-stage outcomes?
The data clearly demonstrates that psychological support is non-negotiable. Intensive counseling, provided both before and after a major procedure like a foot amputation, significantly improves the patient's psychological well-being and their overall quality of life during the recovery and adaptation phase.
It's a recognition that the trauma is physical, metabolic, and deeply psychological.
It has to be treated as such.
Beyond medication and surgery, what are the emerging non-pharmacological methods being used to improve QOL for these chronic pain patients?
We're seeing a major shift toward biopsychosocial interventions. Cognitive behavioral therapy, or CBT, is now recognized as a highly effective new way to manage the chronic pain component.
How does that help?
Studies show that CBT, which is often delivered virtually now, can significantly improve overall quality of life metrics, reduce subjective pain intensity scores, and improve physical function in patients dealing with chronic pain. It helps patients manage their reaction to the pain, even when the underlying cause remains.
That summarizes the current state of management. It is clear that despite decades of research, we've kind of hit a scientific wall. Let's conclude by looking at where the science is focusing now to break that logjam. What is the cutting-edge research in metabolic reprogramming?
The scientific community has largely agreed that the old model, the glucose-centric, single-pathway model that focused almost entirely on L-dose reductase inhibitors, failed because it's just too narrow.
Right.
The shift now is toward understanding global whole nerve metabolism and the complex nutrient overload caused by the combined effects of sugar and lipids. Researchers are trying to map the fundamental energy dynamics of the nerve itself.
So what are the critical questions they're asking to fundamentally redefine the pathophysiology?
The focus is squarely on bioenergetics, for example. Is the peripheral nervous system metabolically reprogrammed, meaning has it permanently shifted its energy utilization pathways during chronic diabetes?
Okay.
What are the specific, separate, and combined roles of excessive glucose and lipids on the nerve's energy production? And that fascinating question we touched on earlier. Does exoglial sharing of energy, or perhaps toxic byproducts, occur between the supporting Schwann cells and the sensory axons? And how does diabetes disrupt that microscopic energy crosstalk?
Why is unlocking these highly specific metabolic secrets so vital to the future of treatment?
Because despite the fact that diabetic neuropathy is the strongest predictor of mortality in T2DM, it remains the only major microvascular complication, unlike diabetic retinopathy or nephropathy, without a specific targeted disease-modifying treatment.
So it's the last frontier.
It is. And advancing our fundamental understanding of basic peripheral nervous system metabolism and energy flow is universally recognized as the only viable path to developing therapies that can truly halt or reverse DN progression.
We have spent the last half hour or so diving deep into the complexities of diabetic neuropathy. Let's quickly review the most critical, striking facts that should stay with you.
Start with the scale. 425 million people affected today, and the projection that by 2050, one-third of the global population will have diabetes, with half of those developing neuropathy. It is a crisis defined by its numbers.
Remember the paradox of prevention. Enhanced glucose control is highly effective for T1DM, thanks to insulin acting as a neuronal growth factor. But that effect is minimal for T2DM, where neuronal insulin resistance has shut down the nerve's own repair mechanism.
We learned that for T2DM, the burden is largely systemic and metabolic. The number of metabolic syndrome components, hypertension and high lipids, obesity, is a strong independent predictor of DN. This reinforces that this is a systemic metabolic poisoning, not just a simple sugar problem.
Right, the nerve is being poisoned by those toxic acylcarnitines derived from saturated fat metabolism. On the pain side, the agony is driven by specific molecular changes. Nerve hyperexcitability caused by the gain-of-function variants or increased expression of specialized ion channels like NaV1.7 and NaV1.8, often aggravated by the diabetes metabolite methylglycol. The pain starts peripherally but quickly causes a restructuring in the central nervous system.
And practically, screening is simple. The 10-gram monofilament and 128 Hz tuning fork reliably predict a high risk of foot ulceration. While exercise shows great promise as a regenerative therapy, pain management relies on the three proven drug classes: gabapentin pregabalin, SNRIs like duloxetine, and TCAs, with an absolute mandate to avoid opioids.
We end today with this final provocative thought for you to consider, drawing on the immense scientific challenge ahead.
The knowledge required to successfully develop a disease-modifying treatment for diabetic neuropathy does not lie in discovering a new chemical, but in understanding an ancient biological relationship. That is the intimate metabolic crosstalk, the complex energy sharing and management between the supporting Schwann cells and the sensory axons they nurture. The future of treating this massive global crisis depends entirely on unlocking the secrets of this microscopic energy diplomacy happening right now inside our nerves.